please feel free to introduce yourself in the chat so you can get to know one another. So I've noticed that we've already, Jessica kind of helped kick that off. So thank you, Jessica, for doing that. And we'll just give it a couple more minutes here so that everyone gets we kick things off with as many people as possible without wasting time, because we don't want to do that, because I happen to know you all who have joined this call are super busy people, so we want to make it worth your while. Mike, good to see you again. Mike is a regular, which I love. Hey, Olivia. Hey, Matthew. All right. We've got a good group. And I think I'll go ahead and get started. And first of all, like I said, please introduce yourself in chat. Appreciate you doing that for us. I do want to encourage you as I'm talking, if you have a question or a point that you'd like to make, this in particular, this is very, we need this one to be really interactive, folks, because, you know, this is new. Nobody really has all the answers. So I think as much as anything else, we really want to have a good conversation. So, and I also want to acknowledge, so in terms of our topic today, which is the CMS Interoperability Framework, number one, kind of really interested in getting some of your opinions about this. And then I'm getting a lot of questions personally about how it overlays with TEFCA. What does it mean for TEFCA? Should we rethink our strategy or not from a national networks or TEFCA perspective? So I wanted to make sure we weave that in also to the conversations. So I think one of the first things that's kind of, you know, just important to sit back and acknowledge is that, you know, like some other government frameworks, in this particular case, it really has no budget tied to it, or at least not yet, no specific funding, not necessarily any carrot or sticks, and has really been operating on a voluntary, you know, sign the pledge model. And there's different groups that the pledge kind of affects different groups of people. The CMS aligned networks, EHRs, providers, patient-facing apps, and payers as their kind of core stakeholders that they're focused on signing the pledge. But so it's definitely you know, voluntary and kind of an unfunded initiative right now. Now, I do think that there's other existing regulatory structures that they will begin aligning with this framework. And so that's one thing that you know, I think we'll start to see. And I think I'll tease some future conversation later in the meeting. I think that is going to start influencing things with TEFCA more directly sooner rather than later. So as some of you have already noticed, I have a survey question. So my first survey question, if you would just please put a note in chat. How many of you have kind of done the homework, maybe taken a look at the cms.gov website and gone through some of the details of the CMS interoperability platform and just kind of have a general idea of what they're trying to accomplish? If you could just put familiar maybe as your answer in the chat, that would be helpful. It'll kind of help guide our conversation. So yeah, I'm seeing Perry, read it all, understand it all. No, I think that is consistent with many of us for sure. one of the things I'm going to highlight is some content that others have created, because if we can leverage what other people have written, I think that's pretty good. Some of you may have seen this in LinkedIn, because one of the things I have pulled up here was by Kristen Valdez, who posted on August 12th, the top myths about the interoperability framework, which I think she has some really good points. I do not agree 100% with everything written there, but that would be surprising given that no one person has the overall picture. So for sure. So the other question is, who has a strong opinion? So I'm going to just I'm seeing a lot of somewhat familiar, some awareness. I'm really curious about who feels strongly about it. Because if you have a strong point of view, I think it's really important that we hear your voice. So don't be afraid to speak up and say you have an opinion, even if the opinion is you think it's bunk, because we've tried these things before and, it doesn't necessarily move the needle, right? I have definitely heard people, seen surveys where a number of people, I think His Talk did one recently. If you're familiar with His Talk, where most of the people just kind of went, yeah, we'll see. We've had a lot of these initiatives in the past. All right. Well, I'm not seeing anyone say they're having strong opinions, so maybe as we go through some of this, we'll pick up some more of that. And just be prepared, because I may call on you, because we do want this to be interactive. So I may ask for some folks to contribute their thoughts. So one of the things that I think was most important about this article, in terms of that Kristen wrote, which is the top 10 myths. Let's see if I can zoom in a little bit here, guys. My control is a little sensitive. Is the centralized government healthcare data. This is creating some new centralized healthcare database managed by CMS. It's one of the first things that I saw in the press that I immediately kind of flipped out about. And it wasn't until that was like, moment zero. And then as I got more information, I started realizing that, well, no, there isn't a discussion yet about them collecting new data and storing it centrally. I'm curious how many of you, again, you can just speak up, or you can put something in the chat. How many of you heard this? They're going to be collecting more health data on us. Anyone hear that one? Okay, great.
I didn't.
Awesome. So that's good, because I think that that was one that scared people really quickly, and created the most negative feelings about it. So I think it was good. Where I got that myth corrected was right after the DC meeting, like literally the same, I guess it was the next day, it wasn't the same day. Commonwealth had a meeting for all of their service adopters and participants, and both Paul, the executive director of Commonwealth, and Liz, their head of product, were there in DC, along with all the other representatives from all the other TEFCA QHENs, and a number of other organizations who signed the pledge. And so there was apparently like a primary meeting and then kind of a secondary meeting that was more focused around TEFCA and included more of the QHENs. And a couple of interesting things came out of that from Commonwealth's perspective. The first one is, no, there's no, plan to aggregate data that they don't already have access through the contracts with CMS, right? The claims data that CMS already has access to. And in fact, it's kind of the reverse. They want to do a better job of sharing that data back to the patient. So I think, obviously that's a good thing. The other kind of myth that isn't listed here, but I think, certainly I think a lot of people were wondering about, and maybe it is listed here. I don't think I picked it up, but there was definitely some question about, oh, this is replacing TEFCA-based exchange, or walking away from TEFCA-based exchange. And so and in fact, it was a little bit, they fell victim to kind of the wording in a press release, I think, and then scrambled a little bit on the day of the meeting to more fully support TEFCA. And this came from, you know, Dr. Keene, ASTP, ONC, and Steve Posnack, where it was like, no, TEFCA is a network. We want TEFCA to be a CMS aligned network along with many other networks. And they definitely see a network of network approach. And they also really value a federated approach, which is, of course, the principle on which TEFCA is founded and other nationwide data exchange initiatives that exist today, right? This concept of federated systems that talk to each other through the benefit of record locator services to help, you know, find where that data is located. I think this first one's an important one. And I think knowing that TEFCA will continue to be a very important part, I think TEFCA will be influenced. And what I know so far, I think it's going to be influenced in a positive way, because I think some of the things they speak to, and I'll come to this later, may be looking to address some of the early issues that we've seen arise in TEFCA-based exchange. Some of the other myths are around maybe getting other tech companies more access to data that could potentially be a negative. And she's just making the point that, you know, there's nothing in the CMS framework that changes compliance guardrails, that there's certainly, you know, the HIPAA umbrella still applies. And in fact, there's some emphasis on maybe adding transparency and doing a better job of letting patients know who is seeing their data and respecting patient consent. So we have, you know, we continue on with this concept that maybe there's an issue around sensitive data might be shared without patient control. And she's just making the case here that the framework is built on this concept of explicit patient consent and putting consumers kind of, you know, front and center. And I think the fact that the framework is looking to put healthcare consumers front and center is a super important aspect that, again, I'm hoping will have a positive impact. So I'm going to stop for a minute. I am curious, what other interesting rumors or assumptions have you guys heard that surprised you? Does anyone have something that kind of surprised you, caught your attention, maybe got you particularly excited?
Marilee.
Yes, Matthew.
Hey. So what I heard, I watched the video, you know, the big press release when RFK Jr. and Trump and a couple other guys were up there talking about this. And one takeaway that I had was I didn't get the sense that, like I think you stated here, that the government was going to push, you know, this new framework, but they were going to invite innovators to help solve this problem. So I guess one of the things I'm confused about is this going to be like another TEFCA or replacement for TEFCA, or are they just saying we're going to add some additional on top of TEFCA, and we're going to use TEFCA, and that will be the framework, right? Like as the care quality 2.0, or this is going to be care quality 3.0, right? That's one thing. So those are a couple thoughts. Like, to me, it wasn't surprising, but I think they're trying to invite innovators to solve this problem, not just the government. And then my second, I guess, a question is, you know, is this going to replace TEFCA, or like, you know, or is it a new framework, another framework?
So, and I'm really curious to have others give their opinions on this too. But the way I'm seeing seeing it as CMS is one, to your point, these criteria are meant to be visionary and illustrate the goals of the initiative. And they're wanting to encourage voluntary participation of early adopters to collaborate with CMS to begin getting to the next layer of detail. And then publish implementation guides, not create necessarily new frameworks. So implementation guides can affect many different ways of sharing data. So for example, an implementation guide could be produced around how a patient might get access via an app through Blue Button to get access from CMS, for example. Or it might be an updated SOP in TEFCA that better aligns with these goals. What it doesn't seem to have, and to me, this is absolutely critical in order for a trust framework to exist that supports this broad-based health information exchange that we see in Care Equality and TEFCA-based exchange, you have to have a common data sharing agreement. And those only exist either within a network like Commonwealth or eHealth Exchange, or within a framework like Care Equality and TEFCA, or within a local health information exchange like our friend Brian at Indiana, or Mike at Reliance. And so what I feel this is doing is setting up overarching goals that no matter which networks you're participating in, we're all kind of trying to move to make the functionality of participating in those networks better experiences for the patients and for the providers, and to solve some of the problems that are just kind of intrinsic to all of those methods of exchanging data. That's the way I'm seeing it. I would love, and in fact, I would love, and I know Brian from Indiana, I know you've not had a chance to spend a huge amount of time in it, but I'm curious if you kind of came away with the same general overlying concept from it. How do you feel it might influence your HIE?
To be perfectly honest, I don't really have a solid opinion yet, and it's more so based on ignorance than sort of having an informed perspective. Right now, I'm just sort of in I don't know. Let's wait and see where this goes mode before I start getting myself twisted around trying to figure out where the Venn diagrams overlap.
Do you think it'll be a big topic of conversation at Civitas in September?
That's a good probably, yeah.
Yeah.
Yeah. And if history is an indication, I don't know that I will come back any smarter, maybe just with more intelligent questions.
Yeah, exactly. Exactly. Mike from Reliance asked, given the history of past networking initiatives, are there any guardrails to prevent one or two vendors from dominating the efforts? I think that's an excellent question. And, if we look at all of the folks who kind of, signed so far, and I will tell you, if you didn't get in the initial group, it's proving to be a little difficult to sign up. I have already tried once. I will probably keep trying, because there's an email that instead of just letting you fill out an online form, you have to send an email, and then, you don't hear back. But these were the folks that, from a, that were kind of there in the White House and have signed the pledge. And it's an interesting group. You have EMRs, which we of course are not surprised to see. We have some vendors like Be Well Connected Health. We have Care Equality, a Commonwealth, eHealth Exchange. Clearly all of the QHINs. I think it's all of them, if not all of them. It was close to all of them. And then some just larger, vendors out there. And they represent the Louisiana Department of Health. So you got a public health entity, My Health Access Network, which is an HIE, CRISP is an HIE. And so it's a pretty broad group of folks. But I know, everyone's worry is that, Epic leads the charge. But I think if you look at all of the different things that they're covering, a lot of these are areas that Epic doesn't necessarily have complete control over, although they certainly can be a blocker. So to the extent, I feel like hopefully this makes it a little harder for Epic to be a blocker, because I can tell you that some of the challenges, and for anyone from Epic on this call, tremendous respect for you guys. You're great teammates to work with in the networks, but you obviously work very hard to protect, your health hospital and health system customers, and those folks have a lot of risk involved that they're trying to manage when they're doing data sharing. So, but some of the things that I found interesting and where we really get an alignment with some interesting alignment with TEFCA is one, this concept of ILA2 identity vetting, which is the requirement for individual access services under TEFCA, getting applied to providers. This whole managing and vetting of providers that we're having to do under TEFCA and now under Carry Quality because of some business rule adoption by some of the implementers is just consuming a huge amount of time. And so if we can come up with some standard ways where providers get credentialed, are in an actual useful, complete, modern national provider directory, and like this one says, does an attestment that the request is for treatment purposes, then there is no more argument of whether in a CMS aligned network, the provider should have access to that data. So this kind of is interesting. And then this delegation model. So those of you doing network-based exchange and Vivlio and some of my other customers, you are a vendor that is sitting next to those big EMRs and having to deal with these new rules around, delegation of authority. And you and me and the other folks trying to manage this process are feeling a ton of pain around this very manual business process that just is slowing the whole process down. And so the fact that they kind of picked up on that, I think says when that RFI came out, they probably got an earful around some of the challenges that these things in TEFCA that were meant to try to address some of the issues that occurred in the network last year may have gone a little too far. And so this is an important role that I think the government can play, is to say, no, we don't want to tighten things down. We want to open things up, and then we want to add a layer of transparency from a patient perspective. That's kind of where we have some gaps today. And then, yes, and Mike, so I think I was touching on exactly what you were talking about, because yes, Epic does seem to be dominating a lot of the TEFCA policy decisions, although I can tell you there's a lot of humans pushing back on some of those concepts. Jim, it says you've had your pledge acknowledged, so that may be because you're right square in the middle of all this with being in the patient credentialing side of the equation. So Jim, why don't you jump in, because you have such great knowledge and experience around this whole patient identity and credentialing side.
Well, thank you, Marilee. That's very kind of you, and yeah, and happy to contribute. For full disclosure, I represent my startup, MyLego. We are focused on offering an interoperable patient identity platform in conjunction with the resources for I-Level 2. And just to comment on a little bit, a lot of what you see here contextually reflects on what the Karen Alliance has been doing for identity development. For full disclosure, Marilee and I have had several discussions on this topic where the concern is that there is a level of overhead and infrastructure for each organization to I-Level 2 their patients, potentially do it again and again because the system doesn't yet provide for reliable, reusable identity. And then what that means for sharing their identity as a patient between hospital A and hospital B, and how hospital B trusts what hospital A is giving. I mentioned the chat, Epic, of course, at UGM focused a lot on Cosmos AI and what they were doing with their ambient AI scribes, justifiably, but they also announced kind of quietly that they were rolling out this Epic ID system, which is an ability to bypass the username and password just to get to my chart and get access to your data at wherever your identity is established at, say, Hospital A. But if you have records in Epic at a hospital B, that same Epic ID for you can be reused at those other locations. And there's also a means that, say you have records at hospital C, because you happen to show up at their ER, so there's an instance of data for you, but you don't have an established relationship in a MyChart instance, that your credentials from that Epic ID could be accepted and used there as well. So again, it's very Epic themed, but they are standardizing around their ecosystem for management of their patients and patient identity management that will reduce friction on the part of the patients. And then from our standpoint, that Epic ID could then could be integrated with another standalone portable ID that's IA level 2 that could be used through an HIE or some other Commonwealth exchange to another provider or something outside of those Epic instances. I hope that's helpful.
It is helpful, and I agree with you. I think that as they're making those changes, it starts to address some of the concerns they have and why they've, been put up some barriers for individual access services, some extra guardrails, but you can kind of see that things are getting chipped away in a positive way. And when you have the federal government saying, guys, this is where we're going, I think that there's no question that should help us over time. And so I really am expecting to see TEFCA. Let's just say I'm going to be extremely disappointed if TEFCA is not influenced in a very positive way to help us be more successful with TEFCA-based exchange for individual access services. And I said in another meeting this week that if we cannot get individual access services working through TEFCA, then we should have never had a TEFCA. Because if you think about it, we were being Care Equality shared 1.5 billion clinical documents in June. It's huge. It's people in the network are shocked on the advisory council that the numbers just keep going up. They're looking for things to slow down. And I'm going, no, it's not going to slow down. That's where it's a snowball going down a hill, right? The more documents that are available, the more success people have, the more providers benefit from that. You're not going to turn that off to go wait around for people to show up in TEFCA. We're going to see, and I think I talked about this, in my last office hours, we're watching this TEFCA cup, if you will, fill up, but Care Equality is doing this too. And until, my customers have multi-network access. And I think that's the strategy. If you're in a national exchange world, you need to be able to support multiple networks, because I think it could be quite some time before it makes sense to move all national data exchange over to TEFCA, and it may never be in the state. We may always be in a situation where certain stakeholders are available here, other stakeholders are available here. And I do think that's the reason why this concept of a CMS aligned network is important, because it helps, it acknowledges that there's probably multiple networks if you have a framework that has longevity built into it. So let's all just be trying to at least row the boat, in the same direction. I would be, based on that conversation, I would love to, has any of that conversation kind of spurned a question from anyone? One of the things I asked was what red flags are going up in your brain? I know what I heard from Matthew is just a concern that, are we just going to keep, changing and evolving networks? And I can't keep, it's just hard as a business person to keep track of these constantly evolving, networks. And so having some confidence that this is the world that I'm building towards, is very helpful as a business owner. Anyone else have any sort of red flags that you're worried about, that's keeping you up at night in terms of your own priorities as a company, as a healthcare consumer, as a provider, whatever hat you might be wearing? All right, I'll let you think about that, since no one's jumping up to put a comment in or speak up. I think the one, and this again, I should have checked the HisTalk survey results, but I think this is the one that I'm hearing most frequently right now from folks that have been in the industry for a while, which is, well, okay, we have this happen every 4 or 5 years. It's just hype. And this idea that we're going to move things significantly by mid 2026, you know, is crazy, especially based on the fact that, you know, there's no money behind this. It's all voluntary. I think this is a good time for a survey. How many of you feel that there really won't be any significant changes happening anytime between now and the end of 2026 from this? Jen says, yeah, I think it's going to take longer.
I just raised my hand because I think around defining, you know, and nothing will happen. Well, I think you did a great job pointing out the changes in the national networks and what you're seeing in changes already. I think awareness and understanding by the average person will have to grow, and they probably won't get that from their provider or health system. And I think, you know, ease and access to resources to take advantage of it are probably things that people will use. So I think there could be spikes either geographically or demographically where this takes off like hotcakes, and then other areas where it continues to lag. And we have to, I think, figure out what the next step for this, kind of back to that TEFCA 2.0 question, is where does a rising tide raise all boats? That's my perspective.
Yeah. And Mike says, I think there will be some change, but not a massive shift. And I would agree with you. I think anytime you have something like this happen, you know, incremental change is probably going to be the result. But if it, you know, what I'm looking at is, can we accelerate certain things? And so if we look at, you know, some of these specifics, where I think acceleration can happen, I think that we are already seeing a huge number. I mean, there's been a lot out there, but I think the patient-facing apps, you know, are now starting to realize that, oh, maybe this TEFCA IAS thing is for real. And then when you layer in the AI capabilities, there's just an explosion in these patient-facing apps that are available to solve certain problems. You know, I use like 2 or 3 depending on which use case it is. But I think that maybe some directionality here can help accelerate patient-facing apps maybe being more successful. The kill the clipboard one is interesting. So I'm gonna put some of you on the spot. I won't call names, but just in the chat, when you hear kill the clipboard, what comes to mind? What problem do you think they're trying to solve there? And we're just going to have uncomfortable silence until someone raises their hands or jumps in.
I'll jump in with a commentary, and I don't mean to dominate the conversation. I think when we talk about electronic health records in general, skeuomorphically, we're still thinking about the manila folder or the clipboard in our mind. There's some record for us that's tucked away, whether it's a manila folder or a real one. What I think this is starting to gradually suggest is to think more in the context of your health data. And I know all of you have been exposed to various things you read about a future where, you know, you have your AI and you have your wearables data and you have your lab tests and you have other environmental information. And all of that is data about you. And it's not just what lives with one doc in one EHR at one system and something at someplace else. And I think that this is kind of a gradual suggestion in that direction. But, you know, I don't want to be overly optimistic, but.
Yeah, my first reaction, and Mike, I'm going to call out your comment in a minute. My first reaction was, why didn't they talk about killing the fax machine? Because I felt like that would have resonated with many of us in the healthcare interoperability space. But once I spent a little bit more time digging into this, as I understand it, what they were specifically talking about is I am checking in at the front desk. And yes, Tracy is mentioning it. And I have to fill out, I mean, we all do still, it's crazy. I have to fill out all this information. And what's even worse is they give me the ability through Phreesia and other apps to do this electronically, but then I still have to fill out a piece of paper when I get to the office. So yes, it is specifically focused around this concept of the patient providing. Well, Mike, you're saying it to bring. I went right where you went. I was like, there's no clipboard. Doctors are using EMRs. They're behind the times. And then I realized,
Oh no,
they're talking about the patient check-in process and specifically. But
to,
yeah, for it, Mike.
that point, yeah, initially when I heard it, I think I said that, but it's been a week or whatever. So, but no, I can tell you right now, I supported a doctor's office for 15 years, and even though they had an EMR, the doctors still insisted on having a patient summary printed out for them to carry into the room and for them to scrawl notes on. Then
Yeah.
they'd send that up to medical records to be scanned in, but that's not accessible because it's just scrawlings on a sheet of paper that they may get a copy of later.
Yeah. Yeah, the good point. I think it's easy for me to think that, you know, oh, and I do have more of my doctors today using a computer in the room than they did 5 years ago. So I kind of feel like that's good, but I'm sure there are still those that, and Matthew and Jenny, who work a lot with provider groups in your role, probably have experienced that. What's interesting about this kill the clipboard thing is, the biggest problem is how hard it is to get data into the EMR. So all of that FHIR endpoint, trying to get EHRs to make their FHIR endpoints available, up until now, it's been almost exclusively read only. And it's because it was designed primarily back in the day from a regulatory perspective to encourage patient asks to be able to do a FHIR connection to the EMR and grab that data. And it was never thought of originally that data needs to go back in. So this kill the clipboard is really the first time that CMS, ASTP ONC has acknowledged that, oh, we got to get data in. And there has been, a big resistance to patients, pushing data in. So you can have providers pushing data into some level, that provider to provider exchange, although that still, in my opinion, is not very good, not very high quality, but maybe we've made some incremental improvement there. But boy, the first time the patients got their name on the data, ooh, we don't want to pick up that data and put it in the system. And so I think, if nothing else, the fact that we're now talking about this actively and that there is some discussion around bidirectionality of the data, not just being read only, but having to go, the other direction, and be able to be much better to be able to consume data into the EMR, is super important. And I'm hoping that we will see, because that's a good example where, HL7 FHIR, and supposedly this is in the specs already. We just have such poor adoption of it. In fact, we just had one of the customers we're working with, we were doing some, recent checking with Epic's API, and we're starting now to see a few more options for writing that we didn't see before. So hopefully this is an example of an issue that's getting ready to swing back the other direction.
But Marilee, on that comment, I mean, I think one of the challenges is there's going to have to be significant organic changes at the EMR level in order. I mean, so, I think one of the stated goals of the CMS Interoperability Initiative, is highly aspirational, exchanging FHIR. I mean, right? Because you're going back to legacy systems that have been around for a very long time and asking those systems to adopt. I mean, it is a major lift, right? Rather than just wrapping. I'm not trying to be negative, just real.
If we try to enforce a specific data standard like FHIR into that data consuming of the data, I agree with you, Matthew. But I also think there are ways of getting data through legacy standards that the EMRs could use, and that's HL7v2. They just need to support it the other direction. And that would be more compatible with their current structures. And so you don't have to pick I think there should absolutely be flexibility in the way that data does get consumed by the EMR to answer that question, that, to address that concern. So as I agree 100%, it's the reason why, there's so little FHIR API support. And they've already talked about, kind of limiting, and this will be interesting because they're also talking about focusing the EMR certification process much more around interoperability instead of all these other requirements. maybe if EMRs have less to do in other functionality, maybe that frees up some development time to try to bridge these gaps. But I do believe that there's enough optional data, there's enough variety of data standards that should allow that data to be consumed if the EMRs have a carrot or an incentive to make it work. And I think also hopefully we create some, some working groups and I think that is part of the concept, right, is to create some working groups to build those implementation guides. Here's a couple different ways. I mean, even if you look at TEFCA, we have multiple ways that we can do TEFCA-based exchange. We can do it through FHIR. We can do it through proprietary API, the IAT standards. So even though FHIR exists, all treatment-based exchange right now is exclusively IAG-based exchange still, because there's no reason for those EMRs to invest in doing something different. That provider-to-provider exchange workflow is already baked into their system. It's expensive to just flip all that back to FHIR. But for new use cases where maybe they haven't invested a lot of energy yet, so they're not rewiring something, that's where I think we're seeing FHIR have more momentum. And Jim gave you a +1, Matthew. So I think you bring up an excellent point.
Yeah, the related conversation was as hospitals look at using large language models and AI, and there's one company in particular that sells data quality normalization services. They were pointing out that it's irrelevant how well EHRs comply with HL7 standards for FHIR, for CCDA, for CDA, and messaging. The schema is the problem, and the schema is up to the individual implementations. And so they're running into cases where LLMs are simply not providing useful output because the semantic interoperability of the data is so bad. What's coming out from the EHR to be used isn't complete, semantically isn't interoperable, and it causes a problem. And I think that's the same for just data exchange or input to the EHR.
Right on.
Yep. And I think the HIEs have been facing that one for a long, long time.
Yep, absolutely.
Yeah. All right, let's jump back here. So I think that maybe the consensus here is, folks, and some of you probably are still thinking about it, is that, yeah, what the best we can kind of hope for is incremental change. One example I would call out, as I start weaving TEFCA in here a bit, is we are on US CDI v6 in terms of published data standard, I guess one that, could be used or is in draft mode, and I may be one version off, so don't hold me to that. But if you look at TEFCA and their minimum requirements for what data elements must be exchanged, it's still based on US CDI v1. So even if all this does is kind of push the CMS aligned network to, get to US CDI v3 in the SOP, and keep moving up that ladder faster, that starts to, it doesn't solve all the semantic interoperability problems, Jim, that you're talking about, but at least we are more consistently getting the same set of data from people. Because it's shocking to me that TEFCA is still sitting there at UCDI v1, because we are seeing, and what I'm hearing from customers and from our experience and working with FHIR, while there's tremendous variation from what you're going to get from FHIR, we are starting to see, EMRs leveling up in terms of their USCDI. And in fact, we have an EMR that we're helping using our CCDA. Actually, it's a FHIR to CCDA transformation service, because they have to be able to produce a CCDA. They started with USCDI 1, and then we're helping them get to V3 before the end of the year. So to me, that was a good indicator that they're supposed to attest by the end of the year that they can support USCDI through V3. And, again, we got to keep TEFCA and the other networks, eHealth Exchange, et cetera, pushing the industry forward. All right, we are at 146. So I'm going to drop right into how, what is TEFCA going to get hurt or benefit from the CMS Interoperability Framework that we've already kind of started covering. And again, I encourage everyone to make comments and notes and thoughts or add questions in here. I do think the focus on patients accessing their data helps improve IAS adoption rates for what is already a mandatory response for QHINs. And that was the whole point of TEFCA, was to help, move the needle outside of treatment, which is where we've had so much success in carry quality, but just very limited success for any other exchange purpose, and certainly individual access services. Like I said, if TEFCA can't make IAS happen, then it shouldn't even exist, because it's just duplicating what we're already doing. The value was this mandatory response for individual access services. What I'm hearing from the QHINs on this front is that up until now, part of the problem is, which surprises me a little bit, is there's kind of no enforcement mechanism for the QHINs. So some of the QHINs have been slow to roll out their individual access services support, even though it's mandatory. I think that, so take that piece of information along with what I was told by our friends at Commonwealth, which is in kind of some side meetings, not the official meeting that people have watched, and have been available online. In that DC meeting, there is some discussion of having ASTP ONC getting back more involved in TEFCA from an influence perspective. And what I mean by that is, at the end of last year, the role of the ONC was really moved more to a veto role, and the RCE and the QHINs were kind of moving more into a self-governance mode. And there is some discussion about maybe that pendulum swung too far, and that ASTP ONC does want to have more influence to be able to take these concepts that they've put out there around the values that the goals that the CMS Interoperability Framework has, and start pushing more heavily to influence TEFCA to go there. And that then helps maybe keep someone like Epic just having, complete control over some of these problematic areas that have created some new barriers, particularly around required treatment, and then just the individual access services, and not putting too many gates between the way individual access services was written as an SOP and the way it should work, and how it's really working with the EMRs when they roll it out. So I think that could be a very positive effect. I think that it can move us forward on, that moving us up the curve in terms of the extent of the data being exchanged. I hope that it will help accelerate new exchange purposes. We've got supposedly 3 new operations use cases that are also mandatory heading our way in early January. But there's a lot of unanswered questions on that front, including the fact that supposedly responders can charge fees, and I've not heard a single QHIN be able to answer my question around what that means, and yet it's basically around the corner. And then hopefully this whole concept of increasing transparency. I mean, one big outcome was, hey, we have for the first time a TEFCA directory. And if you don't know where that is, let me know. You can email me, and we will tell you. I'll send you the link. So I think most of you have my email, but just in case you don't, I'll put it here. You now, for the first time, have the ability to go and look up, providers under TEFCA, and it's a big list. We have over 9,000 unique large health systems listed, and over 41,000 individual participants. And my bet is we're going to check it at the end of August. So I will be able to report on my next office hours kind of what we're seeing that growth rate to be. This whole issue that some of you are familiar with, where this required treatment definition, has this very specific language around you must be a covered entity. One of the things that, if I can find it here real quickly, that I feel, it's sitting right here, is that, they're looking to address that in terms of recognizing that providers need full treatment access. If they've jumped through a couple of hoops that are more easily scalable than filling out questions on an Excel spreadsheet like we're using today, then we should stop questioning their right to get data under treatment. And then also this acknowledgement that for delegate of authority, as long as you have you have a business associate type situation existing and in place, then that works, and you don't have to jump through, so many hoops. And specifically, they're talking here about, reciprocity, unless, there's some sort of contractual agreement to do so. I think both of these things are clearly trying to address issues that we're running into TEFCA, and then that's all kind of now flowing down into carry quality as carry quality looks to align. All right. We only have, about 7 more minutes. I want to open it back up to the group. Where do you see CMS Interoperability Framework perhaps derailing, distracting, maybe negatively impacting TEFCA, or maybe you just have a question or concern that you have thought of recently here?
Marilee, this is Martin in Pennsylvania.
Hey, Martin.
Whenever we thought that TEFCA might not survive the new administration, there was an effort to, as part of carry quality, to do a carry quality 2.0, and thinking that that would be the successor to TEFCA. Now that TEFCA is, gotten new life breathed into it by the administration, I guess I'm wondering what's going to happen to carry quality. And second point, relative to the pledges, I'm trying to understand whether it makes any sense for the statewide health information exchange in Pennsylvania that is aligned with a lot of the new direction, and thrilled that the federal government recognizes something other than TEFCA as a meaningful solution to interoperability. Trying to understand what the pros and cons are of actually pledging to support facets of the new approach.
Those are 2 awesome questions. Let's start with the second question. I'm not personally seeing the downside of pledging, and I would love to see more HIEs and state entities or regional entities signing the pledge outside the scope of TEFCA participants, because a lot of those HIEs that sign are, participating with QHIN. So I would love to see some broader, regional health information exchange folks signing the pledge, because I think it's important they have a seat at the table and they have some influence. And so maybe there's smarter people than me that could talk about potential negatives, but especially if the HIE, and I know they have been pretty closely aligned. I mean, they've been doing a lot of innovative things there in the state for quite a while now. And so I'm not necessarily seeing the downside of that, particularly since it is voluntary. And but I think it's a way of getting more influence. And so that I would recommend it from that perspective. In terms of that kind of alignment with TEFCA that you're talking about, the carry quality was important to the steering committee, coming out of last year. And it's interesting because for the first time on our Carry Quality Advisory Council meeting this week, people were starting to ask the question, and this was when we were looking at the volumes, and people were surprised about how we kept growing and growing in carry quality, and wait, I wasn't necessarily expecting that. And we were even talking about, putting some metrics in place to look for signs that maybe that's shifting. So I think that's important from a numbers and information gathering. But, and we do see that TEFCA adoption is growing faster than the early carry quality days. So that's one of the things that the carry quality team decided to take on, is to do some measurement to start to look for those signs. I don't know what's going to happen with alignment You know, and I think we're just all waiting for the steering committee to come up with some more guidance. But I think that the numbers are telling them one thing, right? Which is, oh my gosh, we just have so much momentum. And at the same time, you know, there's this focus on making sure that TEFCA, that with this momentum that's building in TEFCA. But I think that in the same way that we've seen eHealth Exchange survive over many, many years, the first network ever that, you know, besides direct care messaging, that was, you know, this kind of query-based exchange framework, still be very viable, you know, important part of the equation. In the same way that we see health information exchanges playing a vital role in their communities, I think care equality is going to continue to have a role for a very long time, because I just think there may be certain stakeholders that are sharing data with each other that are maybe outside the core EMRs, but are still really important to providing good care to patients. And until we end up with, you know, until it just gets to a tipping point that, you know, everyone's there, you know, then okay, we can shutter the lights. But I think that could take quite a long time. But we're going to have to watch it, because that momentum could shift at any time. Excellent questions. Thank you so much. All right, folks, we are 3 minutes away to end time, and I don't want to hold people late. I will hang on for a few more minutes in case someone wants to throw another question my way or has a comment to leave us with, but I just want to thank everyone for attending this session. Hope that it was helpful, and hope that you'll join us for the next one. I don't have the topic yet, so if you have a suggestion of a topic, please email it to me.
Thanks.
Bye, everybody.
Thank you so much, everyone. Bart asked, while people are leaving, if anyone wants to stay, Bart asked, are you tracking the volumes by care equality versus TEFCA monthly? If so, can anyone share it? No one is publishing that data yet that's publicly available, Bart, but this is kind of what we were asking for in our last advisory council meeting. So if they start publishing those stats, we'll definitely make sure you get included in that.
Thanks.
No problem. All right. Thank you, everyone.